Hey there, everybody. This is Richard Slama, and I'm one of the ER residents. And today we're going to be talking about acute coronary syndrome. So, again, this is a really scary presentation, at least from the emergency department standpoint. One, because the morbidity and mortality is so high, and because it's actually one of the easiest things to miss in the emergency department. All the risk factors below apply: diabetes, hypertension, hypercholesterolemia. So when you think of this disease, you want to think of it along a spectrum. So if you kind of follow this diagram from left to right, you're looking at a normal blood vessel, no plaques whatsoever. And then you get on to what's called a stable angina. So over time, this plaque develops and there's a very fixed stenosis in the vessel. And the person with this, which is called stable angina, will get chest pain, usually on exertion, that kind of goes away on its own. Prinzmetal's angina is a non-occlusive type of angina, which is mostly from vasospasm. But if you go over to the next one, unstable angina, is that there has been a rupture of that once stable plaque. There's a small thrombus that is not 100% occluding the artery. But in this case, what distinguishes this from stable angina, is that these patients will get unpredictable amounts of chest pain even when they're not exerting themselves. And so this is a much more dangerous type of chest pain for a patient to experience, as this clot can propagate onto the next stage, which is a full-blown myocardial infarction, where the artery is 100% occluded, and at this point the patient is actually having transmural myocardial infarction. So all along the disease spectrum, and there's all those variants possible. So in terms of diagnosis, you want to start off with your history and physical, an EKG, and most patients are going to get cardiac enzymes. In terms of your history and physical, your patients will, although they do present atypically, the most typical presentation is a crushing substernal chest pain or pressure associated with nausea, diaphoresis, radiating down the left and or right arm, radiating up into the neck. And again, all these symptoms can vary. And if you think about it, diabetics can even have, and especially diabetic women, can have very subtle symptoms from even epigastric pain or just nausea without any chest pain. Probably the most important single thing that we do as emergency physicians is interpret EKGs to look for any signs of a myocardial infarction. So in terms of the diagnostic criteria, you're going to want to have ST elevation of 1 millimeter or greater in 2 contiguous leads. And what contiguous means is that they have to fit an anatomical distribution, which I will explain later. And this is also followed by reciprocal, meaning it's in the anatomically opposite leads. You're going to have reciprocal ST depressions or T-wave inversions or Q waves. That's the very basic criteria. There's a lot more, but we'll keep pushing forward here. So when you think of the anatomy, and this becomes important when you're trying to correlate where the diseased vessel is, you've got the 3 main vessels that you're worried about in terms of heart attacks. First is your right coronary artery over here on the right, followed by your left main coronary, which branches into the circumflex, as well as the left anterior descending artery. So the reason that this becomes important is because you can actually correlate where the diseased vessel, where your EKG changes are actually correlating in terms of which vessel is causing ischemia. So if you think about it, your right coronary artery, if it gets blocked off, you would expect either a posterior or inferior infarct. So that would be changes in 2, 3, and AVF. If you're looking at an anterior or septal MI, you're going to be looking in the distribution of V1 through V4 for your elevation. And then if it's a lateral, out into the lateral left circumflex artery, you would expect changes in 1 AVL, V5, or V6. Now, this is just a very small rule of thumb, but generally you can anatomically locate where this person is having an infarct. And again, this just kind of reinforces and goes into a little bit more detail. I'm not going to dwell on it too much. All right, so let's go ahead and take a look at this particular EKG. And what is your diagnosis? Give you just a second. All right. So I'm going to go ahead and go through it here. So if you look here, we've got elevation in 2, 3, and AVF, which is 3 contiguous anatomical leads. So 2, 3, and AVF, which means it's either a posterior or inferior MI. And if you look out here in the anterior leads, so V1 through V3, they each have some ST depression. Most notable probably in V2. But V1, V2, and V3 all have some amount of depression. So you have 3 contiguous leads with reciprocal changes in the anterior leads, which means that this is an inferior STEMI. Okay, so on to the next topic of discussion is going to be cardiac enzyme measurements. Now these are always very, very helpful, not so much in acute myocardial infarction, but in patients with unstable angina who are having troponin leaks. If a patient is having an ST elevation MI, you don't want to wait for your cardiac troponins to come back to call what we call a STEMI alert. You want to base that off your EKG findings. But these become more helpful in kind of monitoring these patients and seeing how much tissue they've actually infarcted. So in the past, a lot of these other markers were used. Really the only thing that we use in the emergency department or that we order nowadays is the cardiac troponin. And there are various types of cardiac troponins, but what you have to know about this is that generally the cardiac troponin starts to rise within 4 to 6 hours of ischemia of the myocardial cells, and that it peaks at around 2 days, and then it takes about 7 days to go away fully. The only other thing that does come up, and that only gets ordered if the troponin is elevated, is the CKMB, which technically comes up a little bit faster. It comes up in about 2 to 3 hours as opposed to the 4 to 6. And it's also useful for monitoring these patients, but typically not used in the emergency department. All right, and so how do we treat these patients? I know that in medical school everybody gets taught MONA, so that's morphine, oxygen, nitrites, aspirin, and then MONA B, some people say beta blockers. Really, there's only 3 things on here that I say that most all patients should get, and really only 2. So in terms of morphine, I only give morphine or opioid medications to patients who are not responding to nitrates or who cannot get nitrates. Surprisingly, oxygen is not given to every single ACS patient. And there's a lot of reasons for this, but the main reason is that if you give these patients who are not hypoxic oxygen, they can actually develop radical oxygen species, and there's been shown to be worse outcomes in patients who are not hypoxic. So in other words, if their oxygen saturation is low, then okay, titrate them to a normal oxygen saturation, but don't give every single patient that comes in 10 liters nasal cannula. Okay, nitrates, I do give almost all patients with chest pain nitroglycerin. The one exception, actually there's 2 exceptions that I can think of in particular to this, is that you do not want to give nitrates to patients who are taking any type of Cialis or Viagra or any of the phosphodiesterase inhibitors, mainly because in this particular situation you can really drop their blood pressure pretty significantly. The second thing that you don't give this for is any time that you're suspecting a right ventricular infarct, and what that would correlate to on the EKG is any type of ST elevation in 2, 3, and AVF. So the problem is if you have a right ventricular infarct, you can actually become preload dependent. So if you're not pushing if your RV is not pushing any blood into your LV ultimately, or your left atrium, then your heart's not going to be able to effectively pump blood. And what nitrates do is they dilate the venous system before the arterial system. And so what you actually end up doing when you give that to somebody with an RV infarct is you drop their preload even more. And they can become profoundly hypotensive. So just always use caution when you're going to be giving somebody nitrates. Aspirin is probably the absolute biggest thing that all patients should be given in the emergency department. 325 milligrams. You can also give 162 because they've been shown to be equally efficacious. It's probably the most important thing. So if you give anything else up there, give aspirin. Beta blockers probably don't need to be given in the emergency department, mainly because they, as long as they're administered within 24 hours, their benefits will be carried over. And then always ask your cardiologist about heparin and Plavix and all the other medications that they may want. A lot of these patients will end up on dual antiplatelet therapy. So again, aspirin, plus or minus oxygen, plus or minus nitro, plus or minus morphine, and hold on the beta blockers, and then heparin drip. And so most of these patients are going to end up going to the cath lab. And basically, the disposition of patients without an ST elevation is way beyond the spectrum of this talk. But I hope you've gotten something out of this. And if you have any further questions, always feel free to contact me by email. And I hope you all have a good day.